Welcome to lecture for Psych 310. We'll be talking about developmental and cognitive disorders. So first, let's talk about developmental systems perspective on psychopathology. And one of the things about this perspective and taking this view towards psychopathology is that all disorders are developmental, not just the ones we talk about here, but all the disorders we've talked about to date are developmental in nature. By that I mean that they're not perfectly stable, right? There was a time for most disorders when criteria weren't met, and frequently the future for an individual holds a time when criteria may not be met either. Even for those disorders where criteria may be met for a long period of time, the expression of symptoms will typically change over time, and or the impact of those symptoms, the distress and impairment, will change over time as well. So they develop, they change. These aren't static entities. So consistent with that, it's sometimes helpful to think about these developmental trajectories for psychopathology and for healthy functioning as well. We can think about people's pathology, their symptoms trending upward or trending downward. We can also think about people being on these kind of developmental trajectories early in life, such that, okay, on your current trajectory, the way things are headed, you'll likely meet criteria within a few years. But just because you're on this trajectory doesn't mean it can't change, right? You might change trajectory. You may, and if you do so, you may not end up meeting criteria for that disorder. Another kind of important aspect of the developmental systems perspective is that context influences the expression of pathology. If you experience recurrent episodes of depressed mood, right, what that will look like depends on your context. And that's your culture, time in terms of 1950 versus 2011. Your experience of depression will be different depending on what time you're in. And 10 years from now, those same types of symptoms might be experienced differently. Gender, ethnicity, all these variables come to play a role. And if two people have kind of the same biological things going on, all these other contextual variables make the expression of whatever's going on wrong different, right? We've talked before, I was kind of remind you again of multifinality and equifinality. Multifinality being that the idea that the same initial status can result in different endpoints. So, two infants born at the same time, maybe even, let's say, identical twins. They start off at the same point. They're born in the same hospital. One was born slightly earlier, otherwise pretty similar. They can end up being very different people, right? One of them can end up having schizophrenia, and the other one, 50% chance, won't have schizophrenia, right? So from the same start point, they could even stay on the same trajectory for a while. Then those trajectories can diverge, right? So people that have the same experiences, two people that experience the same trauma, one gets PTSD, one doesn't. There are multiple final outcomes, multifinality, multiple final outcomes from similar experiences. And then equifinality being kind of the other side of that people at the same state, the same endpoint, can have reached that point from multiple different paths, right? So two individuals suffering from generalized anxiety disorder. One may have had a parent that also was very anxious and modeled anxiety for them. The other may not have had that. Their experience of anxiety may come from something else. Right? So there's lots of different ways to get to these experiences of pathology, these diagnostic categories. And then kind of the big point here, which is a lot of words here, but that multiple and interacting events and processes shape adaptive and maladaptive development, and that there's a lot of stuff in that point there. So there's multiple events, so things that happen at now points in time, but then also processes, so things that continue to happen, the way people see the world, people act in the world, biological processes, the rate at which enzymes break down certain materials, all these processes, and they don't just affect behavior and pathology in an additive sort of way. So, oh, it's this plus this plus this. No, it's this very complex interactions. Okay, well, when this happens, it may influence this thing happening, but at the same time, that will reduce the likelihood of this other thing happening, which will increase the likelihood of this thing happening. So it's all these moving parts that are all interacting together to shape development. And the last part is adaptive and maladaptive development. In this class, typically we focus on the maladaptive things, right? And maladaptive development. How do people get to, have meet criteria for schizophrenia or major depressive disorder or obsessive compulsive disorder? What we don't talk about is we don't talk enough about is, well, people who don't have any psychological disorders. How did they get there? Like, so if they are exemplars of adaptive functioning, what are the events and the processes involved with adaptive development? Okay. So keeping that in mind, let's now talk about some of the disorders that feature extensively in human development, and also later we'll talk about cognitive disorders. So when we talk about development, the first thing that comes to mind is, well, human development will often focus on kids because there's a lot of stuff that goes on developmentally early in life. Unlike some early personality theorists thought, development doesn't stop after you get out of puberty. We do continue to develop and change, and there are important psychological and physical changes. But since there's so much change going on in childhood, we do pay some special attention to childhood psychopathology when we're talking about developmental disorders. First off, kids are weird. They're different, and I say that lovingly. They are not small versions of adults. So any understanding you have of adult psychopathology, you can't simply say, okay, so when a kid might have that too. It's just the same. They're just shorter. No, they're very different. They think differently. Right? If you remember, hopefully you've learned about Piaget's theories about how the way that people think changes as they get older and build information through this constructive process. So they think differently. They feel different. Their brains are wired different. Their brains are still developing, as I think adults are developing too, but the rate of development of the brain is pretty rapid still throughout childhood, and then you have puberty with all these hormonal shifts and all these other things. So it takes really special expertise to diagnose and treat children. So psychopathology in kids isn't the same thing as that in adults. It's different. Is there such thing as psychopathology in children? A lot of people say no. Childhood is a carefree, happy time, and kids don't really have disorders. If they do, that's really rare. Hardly any kids have stuff, unless parents have disorders. Then maybe. Unfortunately, they are fairly prevalent in terms of not necessarily disorders, but excuse me. Just kind of psychological problems. About half of the kids in the U.S., according to one survey, report having multiple fears and report experiences of either bedwetting or nightmares or temper tantrums or other behavioral difficulties. Okay. Not necessarily rising to the level of disorders. But along with these kind of common psychological difficulties, about a fifth of all kids in adolescence in North America, now I kind of broadened the survey, have a diagnosable psychological disorder. Right? A fifth, that's a lot. Right? So yes, psychopathology does occur in children, and it's different than adult psychopathology, but it may be related to adult psychopathology. Right, so there are some disorders of children that have adult counterparts. Right, there are certain things that we just talk about that. Okay, that's something we pretty much only see in kids. There's some things that we see in adults and kids. So some of the stuff we talked about before applies to children as well. Depression. Yes, kids can suffer from major depressive disorder, but it looks different than in adults. That's why when you look at the criteria, they're usually slightly different. When we say, well, in children, you can have irritable mood. Just like in PTSD, the re-experiencing criteria for children are different than they are for adults. So there's some disorders where these kind of adult counterparts. There are some of these disorders might first appear in childhood, then continue on into adulthood, with just the way that symptoms are expressed changing as the child matures into an adolescent and then an adult. sometimes disorders are first diagnosed in adulthood, but retrospectively we can look back and see that the risk factors were present in childhood. And then there are some disorders that occur almost exclusively in childhood, and we'll talk about some of the things that are commonly diagnosed in childhood. You have your behavioral disorders, which include things like attention deficit hyperactivity disorder, ADHD, right? Which adults can be diagnosed with that as well too. We'll talk a little more about ADHD in a minute, so I'll save talking more about that. And then oppositional defiant disorder, ODD, is where adults aren't diagnosed with that. That's strictly a child diagnosis. Kids that refuse to do what they're told and are oppositional to a pathological degree, which most kids say no. Some. This is saying no more than 90% of the kids would do. So kind of high end of oppositionality becomes labeled a disorder. And then conduct disorder, which we talked about before when we talked about antisocial personality disorder. Remember, you have to have signs of conduct disorder before 15 to be diagnosed later with antisocial personality disorder. So conduct disorder is in some ways the child version of antisocial, but not necessarily having that disregard for the rights of others so much, but a lot of rule breaking, fire setting, getting in fights, running away, things like that. So we have those behavioral disorders, the developmental disorders, which are more kind of pervasive developmental disorders, which these are developmental in terms of there are some disorders that they're characterized by delays in development, where kids stop developing appropriately or even have regression in development. That's why we call them developmental disorders. So things like the autistic disorders, which we'll talk about those in a bit. Rhett's disorder, which occurs almost exclusively in females and young girls. They have head growth deceleration, loss of purposeful movement in their hands. So babies these little girls that they seem okay when they're first born, and then all of a sudden development kind of gets arrested. They often have mental retardation. Childhood disintegrative disorder, which can happen in boys and girls. So where kids may have 2 years of normal development, then all of a sudden things that they could do, they stop being able to do. And again, these are really thought to be not necessarily, or they're not because something tragic happened in their lives, but some sort of biological thing that we still haven't figured out yet. And then pervasive developmental disorder, not otherwise specified, which is that category of, we don't know what it is, but you have these delays in development across the board. We don't know why, so you get the PDD NOS label. So developmental disorders, learning disorders, for reading, math, and writing. And this is something that's the way it's thought about and assessed and treated is changing in the past couple of years in conventional ways. For a long time, learning disorder was thought to exist if, when you're given the standardized assessments, your IQ was up here, at kind of the normal range, but then your achievement was down here below normal, 1.5 generations below normal, and you had this achievement intelligence discrepancy. Okay, well, you're really intelligent, but you're failing in math. That's a learning disability, a learning disorder. Right? And that discrepancy model has gone away because it even though at first glance it makes sense, you look more closely at it, it doesn't make sense, especially if you know how intelligence tests work. Because if you really have problems, a learning disorder, you have problems with math, dyscalculia, you're not going to do very well in any intelligence test that involves math. So now what they look for is a deficit on an IQ test, on a measure of cognitive ability, which is what IQ tests are, that matches a deficit in achievement. So yeah, you stink at math, and here's the way that you think that is also below average related to your poor math performance. So, no side note there. Feeding disorders, pica, which is eating of non-nutritive substances, dirt, crayons, which all kids do some, but kids that have pica do it a lot, to where it rises to the level of disorder. Rumination disorder, where they'll actually, regurgitate food and then eat it back down. Feeding disorder of infancy, and this is those kids that often failure to thrive, that just don't eat, despite doctors have ruled out any kind of gastrointestinal problems or motor problems. There's no reason for them not to eat, but they're not eating, and that's thought to have some sort of psychological component. And then your elimination disorders, enuresis and encopresis, right? Voiding of urine in inappropriate places, or voiding of feces in inappropriate places. So bedwetting, pooping yourself. If it causes distress, then you can get diagnosed with a disorder. And then last, tic disorders, which have a motor tic disorder, vocal tic disorder, or if you have both motor and vocal tics, Tourette's, which is one that most people are familiar with. Sometimes people just have just a motor tic or just a vocal tic, but if you have both, then it's Tourette's, where you have these uncontrollable behaviors, right? Which a motor tic is uncontrollable motor behavior. Could be the twitching of an eyelid, moving of a hand. Vocal tic. People often think about what they see on TV with Tourette's, with cussing, and that happens sometimes, but more frequently it's throat clearing, grunting, other kind of noises that don't carry meaning, but they are difficult to control. So there's kind of this sense that, okay, here it comes, can't stop it, and then and then people, when they get stressed, the tics are more prominent. So it does have a psychological component, definitely. Okay, so we'll look a little more closely at one of these, the one that people usually are most interested in talking about, and that would be ADHD, Attention Deficit Hyperactivity Disorder. So DSM criteria: 6 symptoms of inattention and or 6 symptoms of hyperactivity. And the inattentive symptoms are things like, makes careless mistakes in the homework, difficulty sustaining attention in tasks, doesn't follow through on instructions, difficulty organizing tasks, hyperactivity, squirms in seat, leaves seat in classroom, has difficulty playing quietly, talks excessively, or impulsivity, which is often paired with hyperactivity, blurts out answers, difficulty waiting turns, interrupts others. So you have a bunch of symptoms, and some of the symptoms, the hyperactive impulsive symptoms or the inattentive symptoms, must have been present and caused impairment before age 7. So people that diagnosed with this kind of adult ADHD, the thinking is, okay, well, you might not have been diagnosed till you were an adult, but we have to be able to go back and look at your school records and see that you had some problems early on. You were getting F's in conduct or whatever because you were talking in class, kind of thing, or your schoolwork was really crappy even though you're really bright, and we assume that it's because you weren't paying attention. Otherwise, we don't think it's ADHD, because it's thought that ADHD is this, in many ways, biologically influenced developmental disorder, where the pathology of the brain difference, the difference in ability to sustain attention and check your impulses, is evident early in life. And if it happens later in life, then that's, okay, the way that we think the brain works, it shouldn't just be showing up now, unless you've done something to yourself, a lot of drugs or a tumor or some other brain damage. Okay, so you have to have these symptoms early on. You've got to show impairment in 2 or more settings, and so this is to keep from diagnosing kids that just can't do well in one setting. Because if it's just one setting, they think, okay, well, that's not really the pathology of the child. That's a mismatch between the child and that setting, right? So maybe they have a really maybe they're really bad at church and really squirmy and fidgety. Maybe they have a really boring church that they go to, and the preacher, pastor, priest, rabbi, imam, whatever, is just really boring and maybe loud, and they get uncomfortable sitting there for a long period of time. And if it's just that, but they do fine at school, they do fine at home, it's not ADHD. You have to have at least 2 settings, and typically kids with ADHD have impairment in a variety of settings. that being said, they don't show that kind of impairment in attention in every setting, right? So I was going to say, well, you say they have ADHD, but they can sit there and play that video game for hours. Yeah, but let's talk about that. And how much effort does it take to sustain attention to this video game that has all these stimuli going off, these noises and lights and all this interactivity? It doesn't take much attention to do that. To sit still in a classroom while somebody's talking about how to do fractions, that takes more attention. So things that don't take a lot of attention, yeah, they can do for a long time. They can attend to those things because it doesn't take a lot of attentional resources to do that. It doesn't take a lot of ability to inhibit impulses whenever you're constantly engaged in something. So they can engage in things and can do stuff for a long time, but only if it has a low attentional demand and there's not a high need to inhibit impulses. Okay. So the impairment has to do two more things, and the impairment has to involve social, academic, or occupational functioning. Usually it's academic, but also social. Sometimes kids with ADHD end up having social problems because of their, especially if they're hyperactive. Inattentive, not so much. Hyperactive often leads to kind of social missteps that might get them ostracized by their peers. And then some rule-out criteria: it's not pervasive developmental disorder, not a pervasive developmental disorder, not psychotic disorder, or any other mental disorder. And then last on this, you can also specify the type: primarily inattentive type, primarily hyperactive impulsive type, or combined type. So if you meet 6 symptoms of inattention but not of hyperactive impulsive, then it's primarily inattentive type. If you meet 6 of the other, you might drift. And if you meet 6 of both, then you have combined type, ADHD combined type. Okay, a little more about ADHD in terms of gender differences. As you might expect, more boys than girls are diagnosed with ADHD. And maybe this is due to some biological difference, the way that boys are wired compared to girls. But it might also be because people tolerate the symptoms more in girls, in terms and kind of the sexual things that are going on. And, if a girl is a little more hyper, she may be socialized to be hyper in a more socially acceptable way than a boy who will be more aggressive and rambunctious. And we also see, I wanted to say this is because there's less of a gender difference when we look at the inattentive type. Another thing is that in childhood, girls are more often diagnosed with the internalizing disorders, depression and anxiety. So the same types of problems that are going on in kids, so some might get diagnosed differently. So some of the boys diagnosed with ADHD might be suffering with kind of depression and anxiety problems, but they're acting out, they're externalizing, and so it looks more like ADHD than these other things. In terms of the course, the symptoms change over time as kids grow into adults, but for most people, they continue to be present in some form throughout the lifespan for most people. But primarily for the inattention, the hyperactivity decreases with time, which, interesting, is something we see in other disorders too, like borderline personality disorder, bipolar disorder. If you live long enough, the mood variations become smaller, right? So there's a movement toward less variability as we get older. What causes ADHD? Well, like everything else, right? Genetics play a role. Exactly what that role is, like everything else, we don't know. It involves the brain, so brain structure and function are involved. There are subtle differences in brain structure or function, looking at kids with ADHD and those without. Again, not enough that we can use to diagnose, but it's thought that especially most of the attention is looking at the frontal lobe, the cortex of the brain, which is involved in inhibition, being able to inhibit impulses, and that area of their brain may be less active. Other things, environmental feedback. So when a child is hyperactive or acts hyper, they'll get different responses depending on their context, right? They may get rewarded for it, they may get punished for it, it may be ignored, and depending on what those consequences are, the behavior will become more or less likely to be exhibited. Right. The inattention probably less responsive to environmental feedback, but the impulsivity and the hyperactivity of those behaviors, even kids that are very ADHD, if they have a very structured environment that rewards them for not acting hyper and punishes them for being hyper, they'll be less hyper. In terms of treatments, frontline is psychostimulants, right? So people always think, stimulants? Why do you want to give these kids stimulants? And again, it goes back to what I talked about the brain structure. That there's the thought is that they have underactive frontal cortex areas that are involved in inhibition. So they need to get this part of the brain more active to calm them down, which is a little bit counterintuitive, but will make sense to you if you're a coffee addict like me. Most of us do a better job at paying attention with some level of stimulant. Right? If you get too much caffeine, you drain part of attention. But we're really trying to study and concentrate hard. Drink some coffee, have some Coke, and you're going to do better. Right? Even if you don't have ADHD. But these psychostimulants seem to work particularly with people that have ADHD. Sometimes other medications are tried whenever the psychostimulants don't work, and it's just kind of trial and error and random things. Anti-seizure meds sometimes blood pressure medication is used, and not always with really well understood reasons in terms of the mechanisms, but they say, hey, if it works, it works. Let's give it to them. And then lastly, behavioral interventions. The drugs work best for the primary symptoms in terms of the impulsivity, the hyperactivity, and the inattention. But all the kind of associated symptoms that go along with that's where the behavioral interventions can really help out. So like the social isolation, the academic performance that's been impaired. All times these kids, if they've gone long enough suffering from ADHD, they've missed out on the chance to build certain skill sets. So they need to learn those skill sets and practice those skill sets to be successful now that they've are able to pay attention. Right. Okay. Moving on now to mental retardation, which is kind of a combination developmental cognitive disorder. Right. DSM criteria: you have significantly sub-average intellectual functioning, which is less than 70 on a standardized IQ test, where the mean is 100 and standard deviation is 15. And there's an ongoing debate about the validity of IQ tests and the meaning of the scores. And there's a general movement in the assessment field away from even interpreting the full-scale IQ score, right? Oh, what's your IQ? Is it 100, 110? Is it 90? Like people that are do testing for intelligence testing, they don't even make much out of that number anymore because there's so many facets of cognitive functioning, and you get scores for each different facet for your short-term memory, for your speed of processing, for your verbal fluency, for your ability to manipulate shapes. There's all these different ways of thinking that being high in one isn't necessarily related to being high in another. So this global score of intelligence isn't that meaningful. And what it means is debatable. So, nonetheless, this is still stuck in our criteria because for a long time people made a lot out of the full-scale IQ score. Eventually, maybe this criteria will change, and it'll be, a certain cognitive deficit, and not just overall this global deficit in intellectual functioning. But that's where we're at right now. Global deficit in intellectual functioning. concurrent deficits or impairments in adaptive functioning in at least 2 areas. So things like communication, daily living skills, socialization, motor skills. So some of the stuff, we think of adaptive, we think about the daily living skills, right? Being able to take care of yourself, personal hygiene, being able to live alone. Talking about adults here. But also there may be impairments in communication, both receptive and expressive, being able to talk, being able to understand, being able to write, socialization, and even motor skills sometimes can be impaired. And some of these things are amenable to treatment, especially the daily living skills. People can learn to do certain things, which means that technically somebody diagnosed with mental retardation, given sufficient training experiences, might no longer meet criteria for the diagnosis, even though it's thought of as a stable, kind of lifelong diagnosis. The onset has to be before 18 years of age. Again, it's kind of like ADHD, where it's like, okay, this is something that has to be seen early in life. If it happens later, then it's probably due to some brain damage associated with either toxin, taking lots of drugs, or trauma, getting hit in the head. Then you can specify the degree of severity, which currently is based on IQ, which again, I'd say look for that to change, because differences in IQ may not be that meaningful. There's probably a better way to look at the severity of the mental retardation. We see from mild to profound. So even above, the 50 to 55 is 50 to 55 up to 70, which there are a substantial portion of people who have IQs in the upper 60s that are not diagnosed with mental retardation because they never had an IQ test, and then they're probably working in low-paying jobs, but they may have never received any kind of special services in school, especially if they're from a low SES family, but they're functioning just fine. They may get married and have kids, but if they ever met a psychologist, they might get diagnosed with mental retardation. But as you move further down, from mild to moderate, less likely to not be diagnosed. People that have a moderate level of mental retardation typically at like a second grade level academically, and usually require supervised living. And then they get below that into severe and profound, then you're definitely going to be living probably in an institution or with a nurse or somebody assisting, especially with the profound. People with profound mental retardation often have multiple disabilities beyond just the intellectual impairment, other physical disabilities as well. So what causes mental retardation? Well, for the most part, we don't know. 75% of the cases are either unknown, or the presumed cause is cultural familial retardation. Right? So really, and I guess the better way to say this, 30 to 40% are unknown, and then another 30% or so are thought to be cultural familial retardation, which cultural familial retardation is, well, we think probably it's genetic, and your parents were kind of low IQ, and then maybe they were in the lower 70s, and then the cultural part comes in that because of their lower IQ, they didn't expose you to appropriate developmental stimuli growing up, which led to this kind of developmental trajectory that your potential was probably in the lower 70s, maybe even upper 70s, but because they weren't able to provide a stimulating environment, your IQ ended up being a bit lower than theirs, or over generations it gets lower and lower, and that's thought to be the cause. But it can also result from maltreatment and deprivation, intentional abusive maltreatment. So those stories you hear about kids that are locked in closets, and chained up and only fed occasionally. Not surprising that they have some mental retardation if you're not stimulated, the brain doesn't grow the way it's supposed to grow. Sometimes a genetic cause, but in terms of identifiable chromosomal disorder, where there's a malformation of the chromosomes or a mutation, like in Down syndrome, is associated with mental retardation. Inherited disorders, PKU, I always mispronounce it, so I'll just say PKU. But they PKU, they're unable to break down certain chemicals in their body, and so if they don't know they have it and they eat certain foods, it causes brain damage, which can lead to mental retardation. Infectious diseases, rubella with the high fever, toxins in utero, alcohol, thinking about fetal alcohol syndrome, and so you don't have to have fetal alcohol syndrome to get some mental retardation from alcohol exposure in utero, right? Because alcohol exposure in utero leads to diffuse brain damage. And how much alcohol? We don't know. It probably depends on the mother and on the child, because people process alcohol differently. It also depends on what time during the gestation. But high levels of alcohol are associated with greater cognitive deficits, and at some point, in some individuals, it's going to lead to mental retardation. Okay, moving on to another disorder that people often have lots of questions about. Actually, two disorders: autistic disorder and Asperger's disorder, which are both more and more so now referred to as autism spectrum disorders. The idea, kind of like we were talking about schizophrenia spectrum disorders, that there's also this spectrum of autistic disorders, with kind of autistic disorder being on one end, no disorder being on the other, and then Asperger's being maybe somewhere in the middle. So DSM criteria both involve qualitative impairment in social interaction, and you have to have at least two symptoms of that. And impairment in social interaction means things like not using nonverbal behaviors to regulate social interaction. Okay, well, what does that mean? How do you use nonverbal behaviors to regulate social interaction? Well, you look at people when they're talking, and if you don't like something to talk about, you might look away. Right? Whenever you're kind of bored with somebody, you have nonverbal ways of showing that. Whenever you're interested and you want them to tell you more, you have nonverbal ways of communicating that. Whether you're aware of it or not, you think about it now, pay attention to yourself, you say, oh yeah, I do that. People with these autism spectrum disorders don't do that. Whether or not they can, debatable, but they don't do it on their own spontaneously. Other examples of impairments of social interaction might be, or other symptoms would be failure to develop appropriate peer relationships. So this is something that you don't look for as a symptom until after toddlerhood, because little toddlers, they don't really have friends. Everything is mine, and they play beside other kids, but not with other kids. So when you're looking to diagnose these things early, that symptom not that helpful, but later on it may be. Lack of spontaneous seeking to share experiences with others, and this is when little kids will bring you something like, look, see, or come here, and they'll point to things or pull you to look at things that they are interested in. And they're big into shared attention. They want you to look at what they're looking at. And if you don't do that, then that would be a symptom of autistic spectrum disorder. And the last one under the impaired social interaction would be lack of social or emotional reciprocity. It's that social give and take, and also that's emotional give and take. So if you say hi to a kid with autism, may not say hi to you, not because they're being rude, just because they don't get that there's an appropriate response. They are missing out on that social rule. Playing peekaboo. I mean, look at you like, that's weird, but there won't be this giggling and laughing as you act silly. Mirroring emotions, So like with a lot of kids, if they accidentally hit you or something, and you're trying to teach them about emotions, and you say, "Oh, that makes mommy sad. That makes daddy sad." You can kind of see a look on their face of concern, sometimes a bit of a mirroring of emotion, and they'll look a little sad. Or if you go really happy, "Oh, I'm so excited," you'll see them smile. They mirror your emotions. Kids on the spectrum, less likely to do that. They don't have that emotional reciprocity. Well, they'll match or mirror your emotional expression. And that's true for both autistic disorder and Asperger's disorder. But then a qualitative impairment in communication, which that asterisk there, because this is one of those things that is diagnostic of autistic disorder, but not Asperger's. This is where they depart. Both have the impairment in social interaction, but only in autistic disorder do you have the impairment in communication, which is a delay or total lack of development of spoken or signed language. So obviously, if you're hearing impaired and you don't speak, that's not diagnostic. But if you don't learn to sign, or there's a delay, and a delay consistent with the norms for hearing impaired individuals, then that might be indicative of autistic disorder. So they often speak late or don't speak at all if they have more severe symptoms. If they do have adequate speech, they'll have an impaired ability to initiate or sustain a conversation, which kind of goes back to that social interaction, but the thing is that this has to do with communication. They may have stereotyped and repetitive use of language or idiosyncratic language. So repeating what you say, having certain phrases they say over and over again. So think about that movie. It's getting kind of dated now, but Tom Cruise and Dustin Hoffman, Rain Man, where he would kind of say yeah. He would say that yeah a lot. You want to you a good driver, right? Yeah, I'm a good driver. And those kind of stereotyped responses were always responding a certain way, using a limited number of words, might be indicative of that impaired communication. And then the last symptom under this category would be lack of varied, spontaneous make-believe play or social imitative play. So they don't do make-believe. So see little kids, taking a brush and singing like it's a microphone. Kids with autism not so much going to do that. Not going to have an imaginary friend, or engage in that kind of pretend play. Okay. And then now back to both disorders. Restricted, repetitive, and stereotype patterns of behavior, interests, and activities. So one symptom of that. So that can look like a couple things. One of the symptoms in this category would be preoccupation with stereotyped or restricted patterns of interest that are abnormal in focus or intensity. So this is whenever they're really into one thing, like really, really into trains, or really, really into dinosaurs, or really into certain commercials on TV, or dates, or statistics. But they'll know a great deal about one thing. Like, wow, they're a genius, but they don't know anything about anything else. And the reason they know so much about that one thing is not because they've read something once and just know it. It's because they obsessively talk about it, think about it, read about it, learn about this one thing. So stereotyped, restricted patterns of interest. Another symptom would be inflexible adherence to specific non-functional routines or rituals. So this is when things have to be a certain way, right? Have to wear these pants, or have to brush my teeth, then wash my hands, and then breakfast. And can't eat breakfast before that. And there can be these kind of catastrophic reactions to little changes in their routines. Is why if you're ever in the airport and there's a poor parent that might have a child with autism trying to travel, and you can see them really melting down and yelling and screaming, one of the reasons that happens is because their routine is changing, and that change in routine can be really anxiety-provoking and emotionally devastating to these kids. They like things done a certain way and always done that way, and that's why it looks a little bit like OCD, right? Another one in this category, stereotyped and repetitive motor mannerisms. So that's like the hand flapping, spinning, motor mimicry, where they'll do the same thing you do over and over and over and over again. And the last one would be persistent preoccupation with parts of objects. So when playing with a toy car, instead of rolling it on the floor like other kids would do, they may just be holding their hand and looking at the wheel and spinning that little wheel and looking very closely at that one little detail, almost as if they can't appreciate the whole because they're focused on this one aspect of the toy. Okay. And then this one has an asterisk as well, so only for autistic disorder, not Asperger's. But for autistic disorder, delays or abnormal functioning by age 3 in social interaction, language used in social communication, or imaginative play. So Asperger's, you don't have to have the delay by age 3, or even the delay. All you have to have is the impaired social interaction and restricted repetitive stereotypes, patterns of behavior, interests, and activities. Excuse me. Okay, so what causes autistic spectrum disorders? Well, one thing we know doesn't cause it are cold, distant parents. This is kind of one of the early theories that parents and mothers, usually, because we always blame the mother, who aren't emotionally warm and giving to the children, create these frigid mothers create these little robotic automatons that are unable to express emotion or be normal because they weren't loved by the mothers. Not the case. Some mothers are like that. Their kids don't necessarily turn out autistic. They often have a lot of emotional behavior problems, but not autism. And most kids with autism have very, very loving, very concerned parents who want the best for their kids. Not vaccines. This is one of the things that sometimes you tell people this, and you can talk about the research, and they'll say, "I know, but still, it happens." Or, "Well, I know one kid," or even "my kid." But there's no evidence that vaccines are linked to autism, and even if they were, which I don't believe they were, they went ahead and took out the preservatives that people thought were causing autism. Ones that were all these thimerosals causing a problem. They've taken those out and put in other ones. So the vaccines now don't even have the things that people thought before were causing it. So they definitely don't cause it now. So please vaccinate your children. No evidence that vaccines cause autism. One theory of what might be involved is an impaired theory of mind, right? So we all, kind of neurotypical individuals, have a well-developed theory of mind. And a theory of mind is the idea that you understand other people have minds and have perspectives and have kind of psychological cognitive activity that goes on that's separate from yours. Right? And these kids have difficulty understanding that others have different perspectives, thoughts, and feelings. And there's some evidence supporting this using some pretty clever experimental designs to measure theory of mind, and that these kids with autism definitely show a delay. They don't do as well on these tasks until later compared to neurotypical kids. So that might be part of what's going on, is they don't get what you're thinking. They have a hard time reading, not just reading your facial expressions, but understanding that you see things different than them, that whenever you see something that they don't see it as well. Which again is appropriate at the very early stages of development, but not at later stages of development. Another theory is the weak central coherence theory, which is the idea that people with autism pay more attention to detail and have a failure to integrate information into wholes. So not able to get this essentially coherent idea. So when looking at somebody's face, we see somebody smiles, and the lips curl up at the corners, their eyes squinch down, the nose may do a certain thing, and there's all these little different stimuli, and you don't notice all those. You just see, oh, they're smiling, they're happy. Somebody with a spectrum disorder, the thinking is, sees those same stimuli, but whereas neurotypical people integrate those into a whole automatically and easily, the spectrum individuals are not able to integrate those pieces, and because they can't integrate them, they can't make sense of them, so they just focus on one piece. And focusing on one piece loses other important information and leads to these different behaviors and experiences. A related theory is that autism may involve sensory integration problems, right? In this sense, because certain textures, colors, and smells can be really upsetting to some individuals with autism, where they won't eat any food that's crunchy or won't eat any food that's soft, and it can be different textures for different kids. Or being hugged. And it's not the emotional connection of it; it's the physical stimulation of being hugged can be very unpleasant for these kids. And can you imagine how that is for a parent when you go to hug your kid and they tighten up or they pull away or they scream, because it's physically uncomfortable for them to experience that. Then another theory, which is one that I find interesting, that individual that has Asperger's disorders, when he was giving a talk, the first time I'd heard about a talk this way, but was to think about this possibly as a variation of an anxiety disorder, because anxiety does seem to be very prominent in autism. Whenever routines are upset or certain textures are encountered, the way they act is very much like a very anxious person acts. And some of the treatments, the behavioral things you do, if you have a child with a spectrum disorder and you're going to travel, you make this little flip book with pictures of all the places you're going to go, and you go over with them. Okay, we're going to go here, you're going to see this. And we're going to go here, and you're going to see this. And if you do that, they will do better. And it seems to be a way of managing their anxiety, because now they know what's coming. So anxiety is prominent, and so in some ways it may be similar to anxiety disorders, including similar to obsessive compulsive disorder. Right? And then, like everything else, genetics and brain functioning play a role. Kids with autism, not always, but not uncommon to see some spectrum behaviors in the parents, especially the fathers, it seems like. Not that they'll have autism too, but they might be a little bit further down the spectrum. They might be in careers like engineers, where being very kind of detail-oriented is valued and rewarded, and being very good at social interaction, not necessary. For treatments, there are no completely effective treatments. No. Even if you hear about, this thing, it works so great, it worked for my kid. Nope, there are no completely effective treatments. Along those lines, beware of cures. Anytime anybody says they have a cure for autism, become very, very suspicious. They are trying to sell something. Or they might be a parent who had success, but unlikely it will lead to success for anybody else. So these kind of instances where kids will get cured, but then it doesn't replicate, it doesn't work with somebody else. And there are a lot of reasons that can happen. One of which is sometimes these kids may not have autism. They may have other things going on that resolve. Like when I was supposed to go see a kid once for an assessment, and kept having schedule conflicts. Finally, 2 months after we initially started to try to schedule it, go to the home, walk in, and the kid pokes his head above the couch and says, "Hi, I'm," what his name was. I'm like, "Hi, how are you?" I looked at the mom, just, "Yeah, he's fine now." I'm like, "Yeah, clearly, this kid doesn't have autism. He's interacting socially with me inappropriately." And she said, "Yeah, I don't know what it was, but he's better now." But she, assured me that he showed all these symptoms before, and I believed her. But something happened and he no longer showed symptoms. So so did he have autism for? Well, he met criteria, but did he have the same kind of biological, neurological things going on as other people with autism? I don't think so. I think there was probably something else going on that led to his behaviors. But you hear about cures, and I have facilitated communication here because it's one of those, not a cure, but one of those things that we know about, that hopefully not to be paranoid, but skeptical. Facilitated communication is this process whereby severely disabled individuals were thought to be able to communicate with their loved ones with the help of a trained therapist, and kind of like a Ouija board, where the person would hold their hand, hold the person with the disability's hand, and you'd ask them a question, and then they would type or write an answer. right? And whenever therapists are trained in this and they believed in it, and they would do it, and families would be crying and so happy that they could finally communicate, because these are for individuals that were unable to communicate otherwise, verbally, sign language, nothing. And so now for the first time they feel this connection, yay! But some scientists had to rain on the party because they said that doesn't seem possible. Let's see. And so they tested it by asking the person a question, and then not letting the facilitator, the person holding their hand, hear what they asked them. Right? And when they did that, facilitated communication went away. I can't do it. They're not responding. They're not responding because the facilitator was guiding the person's hand. And there's probably some instances where people were doing it on purpose and ripping people off, but there are plenty of other instances where they weren't doing it on purpose. They may have felt, I feel like kind of a twitch. Yeah, they're probably looking for the Y for yes, and the next will be the E. And so their own expectation was driving that communication. And so facilitated communication has been debunked. It doesn't work for these individuals. And if the message doesn't get to the facilitator, then there's not going to be a response, which suggests that the response is coming from the facilitator and not from the person with the disability. Along those lines, there's a lot out there about diets, gluten-free, casein-free diets, and some people swear by them. Oh, yeah, it works for my kids. There are no studies yet that have documented the effectiveness of any diets for autism. And the thinking goes for some individuals that they have too much yeast going on in the stomach, and there's too many byproducts that are getting in the bloodstream and going to the brain, causing the brain damage. And if we get their GI system regulated, it'll all be fine. And sometimes kids will get better when parents do these intense diets. Not cured, but better. And one of the reasons they might get better is because now the parents have a place to direct their anxiety, right? Well, now I'm doing something, the parents feel better about it, reduces their anxiety, which will reduce the child's anxiety, and the kid will also get lots of attention, lots of interaction, which is generally good for kids. But again, be wary of those. I'm not going to say they don't work, but be wary. I was working with a family once, and I found out the doctor had prescribed the child GABA, right, the neurotransmitter GABA, in pill form, which, if you take GABA, it doesn't do anything, right? You can't digest GABA and have it go to your brain, right? We can't introduce neurotransmitters that way. Otherwise, there'd be serotonin pills out there, right? And they're not, because it doesn't cross the blood-brain barrier. But some of these, and that guy was a quack, and he's been discredited. But some of these people out there will, offer these false hopes, and a lot of these parents are really looking for anything that might help, and willing to believe in these things, which is unfortunate, because it often ends up draining resources that could be better used. And in terms of medications, again, nothing yet that's found consistently to work. Sometimes some of the same medicines used for ADHD, probably for the same reasons, not the psychostimulants, but the other ones, blood pressure medication, whatnot, that are able to kind of help calm children, kind of mood stabilizing effects, are used. But again, not to treat the autism, but just to help manage the behavior. In terms of therapeutic interventions, there's a lot out there. The most well-researched approach is ABA, Applied Behavioral Analysis, which is very effective at improving behavior, but very intense in terms of time, energy, and resources. And a professional teaching a child step by step, to do a certain behavior, to be able to sit at the table and eat with a fork and knife. It could be months building toward that with lots of reinforcement of approximations of the behavior. Getting them to sit at the table. Work on that for a couple of weeks. Get them to pick up the fork another couple of weeks, and then you go on and on, but step by step in a very kind of systematic fashion. But it does work if you're able to do it. Okay. Move on now to the cognitive disorders. Delirium is one of them. We won't talk about all of them. But delirium is something that you may have heard about, have questions about, being delirious, right? It involves a disturbance of consciousness with reduced ability to focus, sustain, or shift attention. Right? Think about what consciousness is, right? Where you know where you are, who you are, when it is. And that sense of knowing who, where, and when is disturbed, and you're not able to pay attention to things that you want. You're easily distracted by things that are in your environment. Associated with that, there's a change in cognition or the development of a perceptual disturbance. So a change in cognition means typically either a memory impairment, disorientation, or maybe a language disturbance where people are unable to articulate words, unable to name certain objects, are unable to write, made a rambling speech, pressured incoherent speech, topic switching, or they might also have perceptual disturbances. And these are not quite hallucinations, not quite delusions, but somewhere in between. They're generally misinterpretations of stimuli. So, a door bangs shut and they think they hear a gunshot. They look down at the folds of their sheets and they see that it's waves in the ocean, right? Or they might even have kind of really closer to hallucinations, people hovering over their bed. And unlike what we see in schizophrenia, most often these kind of misinterpretations are more commonly visual in nature in delirium versus what we see with psychosis. Delirium, the course, develops quickly and then fluctuates. So you kind of come back out of that blur and regain a sense of consciousness, but then back in. So in and out of delirium. Typically, there's extreme confusion in these short periods, and then brief moments of lucidity and rational thought. And for most individuals, the symptoms are worse at night, and obviously don't sleep well. And then the last part is it's also due to either a general medical condition, substance intoxication, or substance withdrawal, or due to multiple etiologies, or not otherwise specified. That's when you don't know the etiology. So usually we have in the criteria not due to a general medical condition, substance, or whatever, but delirium, you identify you diagnose a delirium by saying, okay, it's all these things, and it's due to this cause. So it's not a rule out; it's part of the diagnosis. You have this disturbance of consciousness because of this brain tumor, or because you're high, right? Which being high won't always lead to delirium, but it certainly can. And delirium needs to be distinguished from dementia, which will often confuse us. That's kind of why we'll talk about these two. Dementia involves the development of multiple cognitive deficits. So again, in delirium you have a disturbance of consciousness and a change in cognition often, but dementia is multiple cognitive deficits, which involve both a memory impairment and then one other cognitive disturbance. Could be aphasia, praxia, agnosia, so difficulty speaking, difficulty moving, difficulty naming things, or impaired executive functioning. And impaired executive functioning doesn't mean that you can't run BP oil anymore, which somebody probably had that. Impaired executive functioning is talking about your executive cognitive functioning, the higher order thought processes. So being able to pay attention, sustain attention, those are executive functions. Being able to put things, objects in order by size, that's an executive function. So some impairment in your thinking. So and being able to plan, sequence, abstract. and then the change represents a significant decline. So it's not just, oh yeah, I'm kind of getting more and more forgetful every day, but it's not a gradual decline. And there, for all of us, if we are fortunate enough to live long enough, there will be a gradual decline in some of our cognitive functioning, especially speed of processing, how quickly we think slows down. But people that experience dementia, they often have that slow decline, and then boom, it drops substantially. There's this shift, and it's usually noticeable. The onset depends on the etiology, which we'll talk about that in a little bit. And how gradual and how abrupt it is often depends on the cause as well. So not surprisingly, the course also depends on the etiology, whether it's slow and continuous or kind of stepwise, boom down further, boom down further, but always worsening. People don't get better from dementia, not much. And there's some of the newer drugs, like Aricept, you might have to be able to arrest the decline momentarily, but you can't reverse it. You can't stop it forever. Other criteria, it's not just delirium, right? So it's more than just that, but you can have both. But the delirium is temporary; it can go away, but dementia, not so much. The other thing, it's often associated with changes in personality. Sometimes this is because of irritability or frustration with the cognitive impairment. So, not being able to remember stuff and not being able to think like you normally could, it's going to make you cranky. It might make you act differently. But sometimes the change in personality will be the result of the disease process that's also causing your dementia. So if you have Huntington's, the Huntington's attacks the part of the brain that causes these cognitive impairments. It also attacks the part of the brain that causes the personality change. And sometimes the personality change will precede the cognitive decline. It can kind of be a warning sign. I said before, the diagnosis depends on the etiology. So dementia, blah, 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 dementia of the Alzheimer's type. That's one diagnosis. And Alzheimer's has a more gradual onset with a slow but continuing cognitive decline. But it's a slower decline, but faster than normal decline. Right? There is a noticeable difference still. And for most individuals, 8 to 10 years after diagnosis, before death. So it's not just slowing your brain down; it actually will kill you eventually. About half the cases of dementia are of the Alzheimer's type. There's also dementia, not of the vascular type, but vascular dementia, which involves multiple strokes. So this is whenever you're having strokes that temporarily cut off oxygen from the brain, right, in the blood, which when you starve the brain for oxygen, you have cell death, and that causes problems. That's why the onset for this is much more abrupt, typically, with a stepwise fluctuating course and patchy patterns of deficits. That means that there are these kind of dramatic declines followed by kind of a period of stability, and then more dramatic declines. It's kind of like this part of the brain dies, and then you don't keep declining because no more brain is dying. Then you have another stroke, so you have more cell death, and then all of a sudden you lose more functioning. And it's patchy in terms of there's some things you can do, some things you can't do, and it's not real consistent. And that's because it depends on where the brain damage occurred. And then a variety of other types of dementia, other general medical conditions that can cause it, including HIV, Parkinson's, Huntington's, Pick's disease, Creutzfeldt-Jakob, which is the mad cow disease, and then head trauma can cause dementia. So, when the brain is damaged through disease, strokes, trauma, or substances, substance-induced persisting dementia, if you drink hard enough, long enough, you can cause dementia. Another important thing to talk about with regard to dementia is its relationship to depression. About a fourth of all people with dementia, diagnosed with dementia, also show symptoms of depression. frequently involving lack of interest, withdrawal, concentration problems, which obviously concentration problems are consistent with the presentation of dementia. But also, depression may result from depressed mood because you are aware that you're not functioning cognitively the way you were before. But then there's also this other phenomenon called pseudo-dementia. Right? Pseudo-dementia is not dementia, as the pseudo implies, but they're cognitive impairments associated with major depressive disorders. So people that are severely depressed might look like they have dementia, but they don't really have dementia. They have pseudo-dementia, and that's not a diagnosis, it's just kind of a phenomenon. And you have to be aware of it to make sure you don't also diagnose somebody with dementia, just because dementia and depression go hand in hand. So pseudo-dementia is characterized by uneven progression over the weeks. So it might get better and then get worse and then get better and get worse again. Dementia doesn't get better, always gets worse. They complain of their memory loss. Oh, I can't remember anything. Oh, it's such a bother. People with dementia, even though they may be aware of it, they're not going to complain about it because usually they're worried about it and or ashamed of it. So they're going to try to hide their deficits, whereas people with depression won't. With pseudo-dementia, depression, worse in the morning. With dementia, it's in the evening. They tend to exaggerate their disability. So again, they'll complain about how they can't think straight, all these things. People with dementia, again, will minimize, not exaggerate their disability. And then obviously, the cognitive impairments improve with treatment of depression. So you put them on SSRI, maybe do some cognitive behavioral therapy to treat the depression, and all of a sudden they can remember stuff again. Okay, clearly that wasn't dementia, that was pseudo-dementia. Okay, remember we talked about delirium before? Also need to be able to distinguish between delirium and dementia, which hopefully it's pretty obvious. They differ in onset, with delirium having a more sudden onset and dementia a bit slower. The duration, delirium is brief, dementia is long. The course, delirium is fluctuating. Dementia, although it may fluctuate some, maybe stepwise, it's always down, doesn't get better. Hallucinations can occur in delirium. Pretty rare for that to happen with dementia. Happens, but rarely happens. And then in terms of having insight into what's going on with them, people with delirium only when during their lucid intervals, and people with dementia depends on the type, but generally they're not fully aware of the full extent of their impairments. And then last, in terms of sleep disturbance, delirium leads to disturbed sleep. In dementia, less so. Okay, so the treatment and management of dementia in delirium, well, it's only some of this applies to delirium. Most of it's about dementia. Neuropsych testing, though, for both. You want to see what's going on with them. And neuropsych testing is not brain imaging, but having them perform certain tasks that are associated with certain brain functions. Right? So that if you fail in this task, we think, okay, well, this part of the brain isn't working the way it should. And it helps doctors then go back and do either brain imaging studies or surgery that's more focused based on the results of the neuropsych assessment. Medications. Now, this is for delirium and dementia. You can, depending on why they are delirious, some medications can restore lucidity. Dementia, again, you can't cure it, but you can help reduce some of the cognitive deficits with some of the newer medications. In terms of environmental and behavioral management, for dementia especially, structure is important. So if they're always going to forget where things are, have things be always in the same place, and kind of structure the environment so that it's easy to find things, it's easy to get around. Exits and entrances are clearly marked. Things are labeled, and there's a big emphasis on safety. With Alzheimer's, you're not going to cure their Alzheimer's, but you do want to make sure that they stay safe and don't get lost or end up getting hurt. And other than that, there's really not much you can do for people with dementia right now. Again, delirium is temporary. Don't worry as much about it. So when we talk about treatment and talk about dementia, a lot of times what we're talking about is support for caregivers, because especially kind of late stage dementia, people become less aware of their surroundings and less aware of their impairments. It's really the caregivers who are suffering, and the people with dementia aren't suffering as far as we can tell. So caregivers need a lot of support. So there are support groups out there. People can talk about their common experiences. The other thing that may be important is respite care, which is giving them a rest. So finding somebody else to help do the caregiving for brief periods of time, so they can go and recharge and do other things that don't involve caring for their ill loved one. Okay, so we've covered a lot of ground on this for developmental cognitive disorders, and some of it widely disparate. But again, the key things to remember are those first things, that all disorders are developmental, and if you can kind of think of these disorders in a developmental context, and not as kind of these static entities. Okay, you have this, you always have this, you always will have this. It's like, no, at this point in time, you meet criteria for this disorder. You got here some way, which may be different for you than somebody else with that same disorder, and where you'll be in 5 years, 10 years, who knows? Might be different for you than somebody else who has that same disorder as well. Okay, that's it for now. Take care.